so it's really means a lot to me to be able to give back in this way. And I'm very thankful for the work that's done by your organization. So shout out to, oh, I thought the dog was trying to come in, to the people, all the people who are living with mental illness and their families. And I want to say a special shout out to my colleagues who are social workers for, sorry, my spouse is trying to help me with the light situation. Special shout out to the social workers, because this is Social Work Appreciation Month, and they really do a lot to help us all. So I'm going to talk today about, let's see. Okay. Thank you. Oh, why, thank you.
The sun's going down and you're going to need light.
Okay. My spouse, Barbara, does a lot of teaching all over the world. Actually, she's a wood turner, and she is the master of the Zoomiverse. So thank you.
I think that'll help. Okay. Go ahead.
As long as it was you and not Floyd coming in, I thought he was going to bust in and start barking.
Right.
So these are some of the things I'm going to try to focus on today. And I'm going to try to turn off my professor hat, because I used to teach medical students and, would get deep into that. This is what the science says, but I am going to talk about science. Some of the things I say might sound controversial. When I talk about science and data, it's not to say that it applies to every single person. People are people and data is data. So if I say something about a medication and you or your family members on it and you don't see it that way, I'm not condemning, any choices that people are making. I'm looking at population-based data. So we're going to talk about diagnosing bipolar, which I'll go into why I think that's important, what diagnoses are associated with it, what are the risk factors, causes, and complications, what to expect over time, and what are some of the roles of the different modalities, medications, psychotherapy, other interventions, and how do we support individuals during their episodes and on an ongoing basis. So bipolar is difficult to diagnose. I think bipolar is both underdiagnosed and overdiagnosed. What do I mean by that? Most people who have bipolar don't first show up with a manic episode. Now, if you've had a manic episode, even if you've been depressed or not, you have bipolar 1, period. End of story. But most people first have depression and later on have mania or hypomania. And then they tend to go to their primary care doctors for that. The majority of antidepressant prescriptions are written by primary cares who have a limited time with their patients and may or may not have time and expertise to screen for bipolar. Also, when people even if they're already having manic or hypomanic episodes, they often don't come for treatment when they're having it. So I think not just primary cares, but every mental health professional, myself included, have stories about working with people with depression who, when I was in private practice, I would have people show up every couple of years and, oh, my depression came back. Okay, let's get back on your medicine. And then a few years later, family member shows up and says, let me tell you what they're like when they're not here, and, describe classic manic episode. But, when people are manic, often they don't think anything is wrong, or if you're hypomanic, you're in the best mood of your life, so you're not going to think anything is wrong. So that's the way it's often underdiagnosed. The way it can be overdiagnosed, that we'll talk about too, is that every mood swing is not bipolar disorder. And so people come in saying, I've been diagnosed with bipolar disorder, maybe by a prior mental health professional, a primary care, or even a family member who says, you got mood swings, you're bipolar, but they may not have classic bipolar disorder. And as we'll talk about, the treatments will be different. So there's basically there are three things we have to think about that cause mood swings. And bipolar disorder is actually lower on the list than the top things. The very top thing is trauma. So trauma being things general, especially childhood adverse events, abuse, neglect. When a kid, doesn't have a parent or parents or someone, an adult in their life who can make them feel safe and teach them how to regulate their emotions, and they don't learn that, they become an adult who doesn't have the skills or the tools yet to regulate their own emotions. And that can show up with a lot of mood instability. Often people who've had a lot of childhood abuse or adverse experiences tend to find situations in adulthood because of that lack of, not knowing what's a safe situation, where they get traumatized again. And so they get even more trauma, and they tend to, react badly to that trauma with changes in mood. So the most common cause of mood swings, of people who come in and say, I have mood swings, is not bipolar. It's some kind of post-traumatic stress disorder. Second most common is from drugs of abuse, particularly stimulants. We all know that there's a lot of abuse of prescribed stimulants, young people using Adderall, high school, middle school, college, street use. And that can cause, Adderall, methamphetamine, cocaine, crack, can cause also some of the cannabis, like spice, chemically lab produced cannabis can cause something that looks exactly like mania. And then, cannabis itself, we'll talk about, people who are vulnerable to psychosis that can be brought on by it. Then the third thing is medical diagnoses and medications. I'm guessing many people some people I'm talking to, either them or family members, have taken prednisone. And while you may not have had a full-blown manic episode, from it, I bet you got kind of speeded up and didn't need sleep as much, and, were cleaning your entire house. But on some people who are more vulnerable or on the higher doses of steroids can get full-blown, all the way manic and look like they have bipolar disorder. And then any medical illness that affects the brain, particularly things like brain injury, stroke, MS, can, present with mania. Linda mentioned my early work was with HIV/AIDS, and that HIV can affect the brain, and that would sometimes present with mania. So, biggest differential diagnosis, biggest thing we want to figure out is bipolar versus trauma, because trauma is more common. So the person comes in and says, I have mood swings. So how long do your mood swings last? If you're having a manic episode or a depressive episode, your mood swing is going to last a minimum of 5 days, 4 to 5 days if it's hypomania, and 7 days or more if it's mania. And it's going to be that way pretty much throughout the day and night. People who are dealing with emotional dysregulation from trauma, their mood swings can last minutes, hours, or at the most a day or two. And they're usually triggered either by interactions with people in their present life, memories, flashbacks, nightmares. In bipolar, they're often unrelated to stress and events. So sometimes stress and life events bring them on. People with trauma have long-standing problems with moodiness and with their mood. And while there may be times when there's more difficulty, it's not a big change from usual. Whereas when someone gets manic, they may not know it, but everybody around them notices that they're a lot different than usual. So that's another difference, is it's episodic and it's a change from usual. And then another thing that people might think they're having mania is sleep difficulties. People with trauma often have sleep problems. Often trauma happened at night. if it was something like sexual abuse, or nighttime, as we all know, when we lay down to go to sleep at night, if we're worried about something, that's when it goes through our head. So a lot of people with trauma don't sleep well. They might have nightmares. They might sleep during the day instead of at night because it feels like a safer time, and nobody sleeps as well during the day. Whereas but they feel really tired if they don't get sleep. Whereas people with mania, when someone's having mania, they get very little sleep, as little as 2 or 3 hours, and they don't feel tired. They just, I was talking to someone a few days ago who said, I wake up energized, ready to go. I feel fantastic, and I just want to do everything the minute I wake up. This individual is on the recovery phase from a manic episode, but he's still having that issue. Another thing that sometimes can get confused, particularly in kids, is ADHD. Because if you look at some of this stuff, kids with ADHD can be moody and have sleep problems. But again, it's present all the time. It's not episodic. Can you have more than one thing? Absolutely. I mean, there's actually a strong correlation between ADHD and bipolar disorder. And then folks with bipolar disorder, because a lot of the reason it's strongly genetic, maybe often had parents with bipolar disorder, and their mood disorder kept them from parenting in the way they would have liked to. So they may have grown up with some trauma or neglect. So you can definitely have more than one thing. So I just wanted to say a few words about cannabis, which, marijuana, which, as you know, the General Assembly just made legal for like 3 years from now, I think. So, I mean, there's some very good, reasons that they made it legal that, I'm not going to address legal and ethical stuff, but just from a standpoint of the risk of people starting it earlier, if it's in the house, it'll be like, it probably is more likely that adolescents are going to get to it earlier because, it's like stealing a beer out of the refrigerator when, mom isn't there or something. And then the whole perception of it being safe increases if it's legal. And the truth is, during adolescence, which is, like up to about age 19 or 20, really longer than that, the brain is in this incredible developmental period, and use of cannabis can really affect, if a person is vulnerable to psychosis, it definitely increases their risk. If someone, in fact, the earlier someone starts using cannabis, the more likely it's going to cause problems. And when I say cannabis, I mean the THC part of it, not the CBD part of it. That it does not affect these receptors that can cause psychosis. It may even have an antipsychotic effect. Not that I'm saying give your adolescents, CBD products, but I'm really talking about the THC. In individuals who are living with bipolar already, regular use of cannabis increases rapid cycling. They have more psychotic symptoms and poorer long-term functioning and disability. And it has direct effects on antipsychotic drugs. The same dose of the drug, instead of staying in the brain, goes more quickly to the bloodstream, so the person has less benefit and more side effects. And both cannabis and tobacco induce enzymes in the liver that make the liver metabolize antipsychotics faster, so they lower the effective levels. So, would I rather, folks I'm working with, drink alcohol or do THC? I'd rather them do neither, but there's downsides to both, but these are particular things with THC. So as we talked about, the place where you really need to catch bipolar is in primary care offices. And there's been a lot of research on how do you do this, since the primary care might have 5 or 10 minutes with the patient. Do you give them a little tablet to have them check off something? So basically the most recent iteration of this is the rapid mood screener, which is 6 questions. And what it brings attention to is, has the person, that really the 2 questions that these 6 questions are talking about is, has the person had manic or hypomanic episodes? And the other question that's not on here is, what is their family history? Because if someone comes in with depression and they have a family history of bipolar, the chances are good that, you know, it may be bipolar. So if it, you know, primary care can at least ask if they've had a period of at least a week during which they were more talkative and more energetic and lost sleep all at the same time. That's going to go a long way, along with family history. Other things are like lots of recurrent episodes and problems with depression before the age of 18. So manic episodes, I'm sure many people, you know exactly what this is, either from lived experience or from, you know, family member. But basically there's 6 things, you know, they have to, it's a distinct period of elevated, expansive, or irritable mood, accompanied by increased goal-directed activity, meaning they're doing lots of stuff most of the time for the minimum of a week. And it's almost always accompanied by decreased need for sleep. As I said before, that means that the person gets by with very, very little sleep and isn't tired. And you know, on the outside looking in, you're like, how can he still be going, you know, night after night, sleeping 2 or 3 hours? They increase goal-focused activities, meaning, you know, they're doing a lot of stuff, and they often start a lot of things. And a lot of the things they do are grandiose, meaning they're probably not realistic. They have more noticeably increased talkativeness or pressured speech, which is when a person talks so fast you can't even interrupt them. You know, now a lot of people talk fast. I'm from New Jersey, right? I talk a little fast, but that's my baseline. You know, that's how I am all the time. If I were, you know, if someone's not normally like that, and it's you can't interrupt them, you can't stop them, and they're going from this topic to that topic, and it's often accompanied by psychosis, but not always. So their grandiosity, their feeling that they're someone special, can reach psychotic proportions. For example, when I was inpatient attending at VCU, we would pretty frequently have the Capitol Police bring people over who were manic and had gone to see the governor because they had some idea that they felt like the governor really wanted to hear. And of course, the Capitol Police, and this was pre 9/11, I can only imagine now, Capitol Police don't take well to people wandering into the governor's mansion. And, you know, usually they were manic. People have excessive pleasurable activities, but up to the point that can cause harm to them, such as excessive sex, you know, to the point of putting themselves at risk for sexually transmitted diseases, spending money they don't have. They put themselves in dangerous situations, in the pursuit of pleasure, speeding, you know, like very high speeds, reckless driving. And even if their mood is very elated and high, it can switch like that from really high and elated to angry and irritable. And they're very impulsive. So it can be very dangerous. It's probably, you know, it's actually more dangerous than depression. With depression, of course, you have the danger of suicide, but people can also have suicidal actions when they're manic because they just act like that. And often they put themselves in situations that, you know, could result in them being hurt or someone else being hurt. So it's truly a medical emergency. And hypomania or bipolar 2 is when people have depression and they have a lesser form called hypomania, which literally means less than mania. It's also a change in functioning and it's observable by others, but it's not severe enough to cause marked impairment in functioning or to need hospitalization, and it's not accompanied by symptoms, psychotic symptoms. So, people who are hypomanic might be kind of annoying, and they're not sleeping as much, but they're probably not going to get in the kind of like legal trouble and stuff that somebody with mania would. And oftentimes they feel more creative and more, able to do stuff. So, they're not going to see it as a problem. But the thing is, and again, everybody with lived experience knows this, that, if you could bottle hypomania and keep it going, wouldn't that be nice? But mania and hypomania are unstable states, and they're almost always followed by a crash down into depression. And people who live with bipolar 1 and particularly bipolar 2 spend about 50% of the time of their time in depression. So the number of times and days and weeks that people are depressed versus manic or hypomanic is much increased. And I think, probably everybody knows the symptoms of depression. They have to be present for at least 2 weeks straight, most of the day. Again, it's not like, a mood swing, like you have a fight, with your mom and then you're in a bad mood the rest of the day, but you're okay the next day. It has to be like most of the time for at least 2 weeks. The mood is very down. In kids, it can be more irritability. And another symptom is what's called anhedonia, which is just not enjoying, diminished ability to enjoy, markedly diminished interest or pleasure in almost all activities. So one person I work with bipolar, his family can tell when he's getting depressed because he's a musician. And when he's depressed, he never takes the guitar out of the case and just, sits and sits and sits. And that's usually what gives him great joy. You can have either weight loss or weight gain, increased sleep or decreased sleep, psychomotor agitation, or slowing down, loss of energy. Even if the person is agitated, they often don't have the energy to do much. And a lot of worrying, a lot of thoughts of death, with or without actual suicidal ideation or a plan or an attempt. But people will often feel helpless, worthless, hopeless, and feel guilty and bad about themselves. One of the things, I used to work a lot with medical patients, and distinguishing like someone feeling sad and grieving because they just got a diagnosis of, a bad diagnosis versus depression is a person who's depressed blames themselves. They feel like they're a bad person. Whereas with grief, they feel the same sadness, but they're not blaming themselves. And they're not thinking, I want to kill myself, usually. So one of the questions was, do people have to stay on medication forever if they have bipolar? Well, the stock answer to that is, yeah, if the diagnosis is right, and again, I'm going to come back to this, is that really the diagnosis? But if the diagnosis is right, probably most people benefit from staying on medication. But then there are people who have a single episode and then go for, and then don't have another episode, or go, 10 years without having another episode. So to argue that they should have been on medication that whole time. I'm a firm believer in, that people are in charge, individuals are in charge of their own recovery. And I will give people information, and I'll give them data and statistics. But, when I was a younger psychiatrist, I did a lot more arm twisting than I've learned as I've gotten older, that it's ultimately the person's decision. And sometimes we're just wrong. We're not able to look in the future. And some people can stop meds and be okay, but that's not generally the case. Generally, when people stop taking bipolar meds, they have another episode. I already talked about how people are depressed more than, they're manic. Unfortunately, there isn't, except people die more often and younger, particularly if they're not well controlled from things like suicide, violence, accidental death by putting themselves into situations when they're really manic. There's also an increased risk of diabetes and cardiovascular disease and respiratory disease. And that's kind of associated with some of the meds we give people and smoking. And then there's a strong correlation. About 50% of people with bipolar also struggle with addiction, particularly to alcohol. It's thought that there's some kind of genetic link between that. And then there's also some self-medication that could go on. Some people struggle with addiction to stimulants because they really like that feeling of being manic and they try to find it when they're not. And I find that to be a particularly hard thing to figure out when someone's had manic episodes, but you're not sure if every time they had the manic episode, was it when they were using crack? And, do they really have bipolar? Do they have to stay on meds or not? To me, those are some of the hardest. There's a higher incidence of migraines in people with bipolar, maybe a higher incidence of some autoimmune disorders. That's a little bit controversial. Women with bipolar are strongly influenced by their hormonal cycle and tend to have more symptoms right before their period, and they're more likely to have postpartum depression and psychosis. And I forgot to put this in, but Linda and I were talking before the presentation about seasonality. And, basically people are more likely to have mania in the spring and depression in the fall. And it has to do with the length of the days. One of the sayings, I think, among some of the bipolar peer support groups is March Madness is not just basketball. We tend to be seeing more mania this time of year. So these are the important things in management. The first thing is safety and suicide prevention when a person's in an episode. And then, we'll talk about medication, psychotherapy, peer and family interventions, self-monitoring, wellness, and self-care. So it's very important to first, to look for those other comorbid diagnoses like we talked about. And I meant to put on the trauma, I think I put on the trauma slide, but I forgot to say, the primary treatment for people with trauma is psychotherapy. Medications are secondary. Whereas for bipolar, medications are a primary treatment. Excuse me. So that's why some people who think they have bipolar and are being treated for it, who actually have chronic PTSD, aren't getting better because they're not getting the treatment they need, which is psychotherapy, which is, particularly focused on helping people regulate emotions. And so if someone comes in, it depends on which phase of the disease they're in. If someone's in acute mania, they're probably in a hospital, and they're probably, the most common treatment I see people coming out of the hospital on are Depakote or valproate. That's the generic name for it. And one of the second generation antipsychotics, which I think you probably know a lot of the names of them, olanzapine, risperidone. And if anybody has ever turned on a television, they know Vraylar because of their commercials. But basically any of the most of the recent antipsychotics are used for acute mania. Valproate is, and then lithium can also be used, but it's not used very much in the hospital. For some reason, people like to really hit mania hard with valproate. So the most common thing I see when someone comes out of the hospital is they're on Depakote and a strong antipsychotic such as olanzapine, which is great for bringing people down from mania. But in the long run, both of those medicines have issues that I worry about. Metabolic issues, they both cause a lot of weight gain. And I don't ever use Depakote in women of childbearing age unless they're using some kind of contraception that that they can't forget to use, because it really messes with fetuses. It can cause, fetal loss. It can cause drops in IQ points. It can cause really, really serious birth defects. So you don't want to have an unplanned pregnancy on Depakote. And of the second generation antipsychotics, you know, some are more likely or less likely to cause weight gain. Olanzapine works really well in the hospital, but almost everybody gains weight on olanzapine. Bipolar depression, there's a much narrower range of things that are helpful. Seroquel, olanzapine, Symbyax, which is olanzapine plus Prozac, Latuda, and Vraylar. Now, and this may sound controversial, but basically antidepressants are something to usually avoid in bipolar, particularly bipolar 1. Many studies have shown that they increase rapid cycling, they can trigger a manic switch, and they're generally no more efficacious than placebo. Does that mean they're never used? No, and sometimes people, you know, if someone's really depressed, you know, clinicians try them, but it really is not a great idea to leave someone on an antidepressant long-term who has bipolar 1. And I say that even though I personally have clients who take them long-term, but usually these are people who are older, who've been on them a really long time. And again, I respect someone saying, I'm afraid to go off of this. I can give them the information and tell them I'm worried, but if they haven't had a manic episode in 10 years, you know, I'm not going to, you know, take their antidepressant away, but I'm going to be on the lookout for any manic switch. So maintenance therapy, the number one medicine that we should be thinking about, and maybe we're using it, maybe not, we'll get to, is lithium, lamotrigine or lamictal, and then some of the second generation antipsychotics, you know, have indication for maintenance. Depakote does not have an indication for maintenance, and in most of the studies, it's been no better than placebo for maintenance. Again, that being said, a lot of people are on it, and a lot of people find it helpful. So I don't take people off medicines that, you know, they find helpful and aren't causing major side effects or risks, like, you know, to a fetus, but I don't generally start people on Depakote for maintenance. So let me say a word or two about lithium. Lithium was an absolute game changer for bipolar. There was never a treatment for bipolar. Nasir Gami, who's the chairman of psychiatry at Tufts and was actually at VCU psychiatry when I was there, has done a lot of research, says it's quite possibly the most effective drug in all of psychiatry because it actually protects the brain. It works in multiple levels in the brain, inducing positive changes in brain structure, and it's, quote, neuroprotective, meaning it decreases inflammatory factors. It also works through neural signaling. It's the gold standard for bipolar 1, and it's the only drug that prevents suicide. Maybe Clozaril may also prevent suicide, but even in people with depression, it's often used if people have very severe or recurrent depression because it does help prevent suicide. Lithium is a salt that occurs in nature. It's not natural in the human body, but when it's put into the human body, it goes through our kidneys the way sodium does. So sodium is what our bodies use to keep our water steady. So, you know, if a person's on lithium, they need to be able to drink enough water and also not to stop eating salt, which unless you're like eating just raw fruit and vegetables in our, you know, culture, you're probably not going to stop eating salt. But people require, you know, you have to have your blood checked regularly. If the level's too high, it can be dangerous, can hurt the kidneys, the heart, even cause death at very high levels. If the level's too low, it may or may not be as effective. It does have some side effects. The most common side effects that would be like increased thirst, increased urination. That's often because it's like salty taste in the mouth, and tremor, and that's often very bothersome to people. But if it's properly monitored, it doesn't cause long-term effects to the kidney. And when people respond well with bipolar 1 to lithium, they generally don't respond well to anything else. And I really don't like to take people off unless there's some strong medical reason. So nobody makes any money off of lithium. It's literally the piece of a rock. And it's been generic since, before most of us were born. So that's one of the reasons it isn't used much, is you don't see lithium commercials, you see Vraylar commercials. Psychotherapy is really key. It's not enough just to give someone a prescription and say, hey, get out there, have a good time. Oh, the other thing I forgot to mention is with antipsychotics, mood stabilizing antipsychotics, is some people benefit from long acting injectables like Abilify Maintainer and Invega. And that's particularly helpful for people who don't think they have an illness, or, aren't good at taking a pill every day, or who are, like maybe they're actively addicted and, staying on a pill isn't going to happen. And that can be a game changer. Some of the medicines we give once a month, some of them you can give an injection every 3 months. So psychotherapy, psychoeducation, and teaching people, particularly in a family and group format, about bipolar. And, even if they've had the disease for a long time, it's kind of like diabetes. Like, there's always something to learn, and you can learn from each other, which you guys, do so well with your groups, as peers and families supporting each other. Cognitive behavioral therapy is helpful for preventing recurrences, particularly of depression, by helping people, think in a different way and change their behavior that may predispose them. It's important to monitor for what's called prodromal symptoms, like to have that kind of talk. And people who do RAP get this in the RAP plans. How do I know if I'm getting sick? Well, it's when I don't sleep so well. Regulation of daily rhythms, especially sleep, is critical. If someone has bipolar 1 and is really, sensitive to that, they could miss as much as like one night's sleep and start to go towards mania. And then dealing with other diagnoses that the person's dealing with, particularly if they're dealing with addiction, is really helpful and important. We talked about how critical peer and family support is, and I'm sure there's like so many stories here that we could probably be here all night hearing about that. Exercise and nutrition, super helpful. Nutrition, believe it or not, there have actually been studies that show that eating a lot of highly processed meats like sausage and bacon and beef jerky can cause more manic episodes. Interpersonal connections, which have been sorely, lacking for a lot of people with COVID, with not having that face-to-face. Activities that bring comfort and pleasure. And of course, this is going to be different for every person, for some people, it's listening to music, playing music, being out in nature, their pets, And then I think the most important thing is this, having something that gives your life meaning, spirituality. And that could be an actual, religion, church, synagogue, whatever. But it could also be, it's anything that gives your life meaning, helps people get through living with a mood disorder. Now, if you're a family member trying to help the person, that you're living with, who's living with bipolar disorder, trying to help them, do some of this, trying to encourage them in that. If they're in like a manic episode, it's pretty hard to deal with them. At that point, your job is to, okay, yeah, I must have left that slide out. If someone is manic, your job is to hopefully try to keep them from hurting themselves or hurting other people too much and getting them the help they need. If someone is suicidal or you think they're suicidal, the best you can do, you should talk to them and ask them. It's not going to make them worse. The biggest predictor of completed suicide is having a firearm available. So either getting the firearm unavailable to them, getting, the ammunition out of the house. That is really a lifesaver because, the episode will pass. I was talking to somebody today actually about, their suicidal thoughts. And they said, well, I'm not going to try suicide again because I failed at it. And I was like, no, I want to put that in a different way. You succeeded at staying alive. And that's a beautiful thing. And he's like, okay, yeah, all right. I succeeded at staying alive. I said, you need to keep saying that to yourself. Don't ever say again, I failed at killing myself, but that I succeeded in staying alive. And that's what we want people to get. You can get through. There is a morning after. You can get through that. So in summary, question and re-question psychiatric disorders, not just bipolar, but any psychiatric disorders. Is this true? If you or someone is diagnosed with something, bipolar, say, and you've been on the medicine and it's not getting better, you want to ask, is this the right diagnosis? What else could I be doing? Could I be adding therapy or exercise? And really keep that in mind and assess for trauma, because that needs to be dealt with specific psychotherapy, but add psychotherapy and peer support to whatever, medications you're taking. Address substance abuse, especially stimulants and cannabis. Don't forget lithium, and I say forget in quotes, antidepressants, in that they generally shouldn't be used. Peer and family support, self-monitoring, and psychotherapy help a lot. And find meaning and joy in life through whatever works for you. So I want to thank you. These are some of the things that work for me. This is my family when we went to the Cowtown Rodeo in South Jersey. Yes, there really is a rodeo in southern New Jersey. And this is where I'm from, Atlantic City. The beach is like my happy place. And this is my downward dog, Floyd, and he and I do yoga together. So those are some of the things that work for me, but we all got to find what works for us. So thank you so much.
Yes, thank you. That was wonderful. Brendan, I know you've been monitoring the chat. Can you speak or ask some of the questions that have come through?
Sure. So there's 8 questions. Let me just make sure. Yeah, there's 8 questions to start. Is it possible to be bipolar 1 and never have depression? Or did I just miss it even though my son never seemed it or said he was?
It is possible to have bipolar 1 and never have depression and only have manic episodes. Yes. It's
okay.
rare, but it's possible.
Okay. What are your thoughts regarding MTHFR gene mutation?
So I have done some reading about it, but I'm definitely not the expert on it. I think if a person has it, they should take that special form of folate that, is helpful, but I don't think it causes bipolar per se. But, any kind of nutritional deficiency or genetic inability to process vitamins, whether it's that or people who have B12 or vitamin D deficiency, should absolutely be addressed.
What about clozapine?
Wow. Yeah. Clozapine is Nasir Gami says lithium is quite possibly the most important drug in psychiatry. I would say clozapine is probably the second most important drug in psychiatry for people with, treatment-resistant schizophrenia. And it also is used for schizoaffective and bipolar disorder. It's not an easy drug to take. It has a lot of, you have to have blood tests once a week for 6 months, and then every other week for 6 months, and then once a month. And it has a lot of weight gain. But I can tell you stories about people who, could not get through a day without, constant voices and psychosis and paranoia, who are now working in school, have, partners in their life. It is an amazing drug for the right person. I think it's not used enough.
I don't know if this was a question or a comment. Treatment with antidepressants sent my son into a manic episode.
Yeah, that's kind of what I was talking about. And unfortunately, that's often the way that people find out they have bipolar is they take an antidepressant and get manic. Yeah.
Someone had asked, when does someone go on maintenance? But I think that was answered when not in an acute manic or depressive episode. Did you want to add to that?
So I think, again, I sort of alluded to this, but one of the, controversies is, okay, what was the person on when they got manic and they were in the hospital? And is that what I continue till death do us part? And I think you have, it's important on the outpatient level to really follow how a person's doing once they're no longer manic. They probably don't need those really high doses. They're going to start feeling really groggy and, not feel functional. And then they're more likely to stop the medicines altogether. And then we really, really have to monitor, side effects, particularly weight gain, which, is bad medically and bad for self-esteem and, it's bad all around. Can people be on olanzapine and Depakote and, get obese? Yeah, but it sure takes a lot of work. So.
Anyone report tremors from Seroquel?
Yeah. Well, you can have akathisia, that restlessness where you can't keep your legs still from Seroquel. If you have tremors from Seroquel, you have to think, is it tardive dyskinesia, which is a whole nother topic. But long-term use of antipsychotics can cause tardive dyskinesia.
Okay. Lithium, could it be effective for individuals without bipolar disorder but long-term depression?
Absolutely. In fact, in Europe, it's one of the first-line treatments for recurrent major depression. Fred Goodwin, who recently passed away, who wrote like the definitive textbook on, bipolar and, really believes that any mood disorder that's cyclical and recurrent treated with lithium if the person can tolerate. I have a lot of people I work with who are depressed who, are on lithium adjunct. Sometimes you don't need the doses for mania. You have to keep the level higher, like above 0.6 to 0.8. And for depression, you can maybe get by with a lower level. And some of the side effects like tremor are dose related. So, but absolutely.
Is it possible to manage bipolar moods without medication?
Okay. If a person has like straight up bipolar 1 and has had more than one manic episode, I'd be very nervous. If again, have we made the right diagnosis? If a person has bipolar 2, maybe. And I think, you got to have everything, all the other stars have to be lined up. Like the person should be, working with a therapist and, have those tools in their tool belt. And they should, be really good about not drinking and drugging and, exercising and keeping the joy factor up in their life. If you can get that joy going and that meaning going, that goes a long way. But, the answer to that is, if you have bipolar 1, you need to stay on meds forever. But I'm not an all or nothing person. And I'd be very presumptive to say that nobody's ever been able to manage without, but it often doesn't go so well.
Does bipolar get worse with age or better?
It depends on how bipolar gets worse the more episodes you have, because it actually hurts the brain, So the key to it not getting worse is to not have very many episodes. And that means, theoretically, when you first, have that manic episode, if you're a lithium responder, just stay on the lithium and do all that other stuff. But but just getting older itself won't make it worse.
How to break through anosognosia. And I don't know if I said that word right. I never do.
Yeah. Wow. Yeah. Okay. I'll tell you that in 2 minutes, right? No, I mean, that up to 50% of people with psychosis have that. And that's just like a Latin term for not realizing that anything is wrong. But, you know, so like, I understand, like, if you don't think anything's wrong with you, why would you want to take medicine, you know? And often people after they're manic don't remember any of it. Even you could even show them a video and they don't remember it. And they often, you know, it takes a lot of consequences before sometimes people do get it. But, you know, you try to find what matters to them. What is the hook for them? So, you know, if they want to see their kids and, you know, a mom who, you know, CPS might take her kids away unless she takes her meds, you know, she's going to have that motivation. If a family says, you know, you can live here with us, but only if you take your meds. If the boss, you know, says you can work here, but not if you, you know, get manic, you know, but you got to find the hook for that particular person and meet them where they are. And sometimes people just have repeated relapses before. They may never get it, but I had this one client who used to say, I'm never going off my meds because if I go off, they'll take me to Central State. She didn't think they took her to Central State because she would get psychotic. She thought they would take her for not taking her meds. So, you know, that wasn't how I saw it, but it was like, yeah, if it keeps you on them.
Okay, 10 more questions are here. So how do you know when to use gene site testing with bipolar disorder?
Yeah, that's interesting. You know, gene site testing is, and I think there's some misunderstandings about it. Sometimes people think it tells you which medicine works for a person. It doesn't tell you which medicine will make your mood better. It tells you which medicine your body can't break down. So, you know, or the level would be too high or too low. So I don't do gene site testing on I don't do a lot of it, but I do it when someone has a lot of side effects to what seem like usual doses to a medicine, or, I mean, that's the most common thing I do it is when, I mean, I had someone who was a very large young man who looked like he would take the maximum dose of stuff, and he kept having side effects. And when we did gene site testing, it turned out he had the metabolism of, you know, like a little old lady in a nursing home. So it's very helpful for stuff like that. But so I do it on a clinical basis, not across the board.
What other disorders that people often confuse with bipolar?
Well, I mentioned, you know, the sequelae of trauma, chronic PTSD, and borderline personality is probably the most common. That and, you know, drug use causing mood symptoms. ADHD in kids and bipolar can be hard to sort out. Anxiety is people who have are more likely to have anxiety and panic. And, you know, sometimes when people get really anxious, they talk really fast. So that might be mistaken, but it's mainly the trauma and the, you know, ADHD and drugs, and then the medical stuff like I talked about.
Best advice on balancing support versus enabling?
Well, I would say your peers, you know, your family to family folks are the best for that because every family is different. You know, I can't put that into 5 minutes. I'm sorry. That's hard though, you know, helping without enabling. And, you know your family member better than anyone else. But, you know, take a look at yourself and a really honest look at your own family that you grew up in and how were you parented or how, you know, and try to know your own vulnerabilities, certainly utilize family to family and utilize personal psychotherapy to learn more about yourself. Groups like Al-Anon, even if your loved one isn't a substance abuser, can also help to understand some of that.
Can you speak a little bit about people who present with depression that are prescribed an antidepressant that triggers a bipolar episode?
So not everybody who takes an antidepressant and gets manic symptoms becomes bipolar, so that alone isn't like, okay, you're bipolar now, but it's a risk factor that they're more likely to, and you definitely want to look for family history and, probably not do an antidepressant. There's also a degree of risk with different antidepressants. The riskiest ones are like Effexor and Cymbalta that deal with both norepinephrine and serotonin. The least risky are the SSRIs, but certainly we've all seen it with SSRIs too.
Okay. Can you experience hypomania in type 1?
Yeah, for sure. And the other thing I don't think I paid attention to that I should have is what's probably know about this, called a mixed episode, where a person looks manic and hyper and restless on the outside, but they feel depressed and have the mood of depression with the energy of mania, and that is probably the most risky state for suicide. But yeah, a person with bipolar 1 can have mild depression, severe depression, hypomania, or mania, with or without mania, or depression with or without psychosis. So it's kind of a continuum.
You said antidepressants don't help type 1, but does it help with type 2? My daughter was diagnosed with type 2 and is on antidepressant, and it remarkably better when she's taking it.
It's not, it's not like as contraindicated with type 2, and a lot of people would say, basically look at the patient, and if they're doing well on it and it's not making them manic or hypomanic, not making them cycle more, I'm definitely not saying, go home and tell your family member stop your antidepressant. Please don't do that. Yeah, with bipolar 2, it's probably a lot safer.
How often is blood supposed to be checked while on lithium?
It depends on the person. When they're first starting, it may be as often as every week or two. Once a person is on a stable dose, provided there's not a change in their health, like their kidneys not doing so well, it could be anywhere from every 3 to every 6 months. As people age, they probably need it checked more often. Also, there's some drug interactions, particularly with non-steroidal anti-inflammatory drugs like Aleve and ibuprofen, that people on lithium shouldn't take. But I would say minimum, even a healthy younger person without kidney problems would be every 6 months. Another thing to be aware of is in the summer months, even the best, plans for hydration, people often get dehydrated. So particularly if they work outdoors or they're, athletes. So I usually run people's, lithium level a little lower in the summer if they're going to be outdoors a lot.
Okay. How much overlap between bipolar and ADHD? Is it common to diagnose with bipolar, but the patient actually has ADHD?
I don't know how common it is. There is definitely some overlap, but remember back yet when I was talking about bipolar is episodic and ADHD is all the time. So if your kid talks nonstop and doesn't sleep well all the time, you're not going to be manic every day of every week of every year. That's probably ADHD. But people can have both.
What was the name of the book you mentioned about bipolar?
Oh, I got it right here. lithium. Wait, it's lithium, a doctor, a drug, and a breakthrough. Walter Brown. Oh, the other book I mentioned. Oh, it's Fred Goodwin and Kay Redfield Houston's Manic Depression, and it's 2 volumes. It's huge and it's expensive. You can probably get it like, if you Google, on Google they have books. There's a lot of good books on bipolar. I could come up with you guys probably have a resource list on the NAMI website, but I can't come up with it off the top of my head, but I'm happy to ask around and do some research.
We could add it when we post the video. We could add
Yeah.
it to the video.
Okay.
How can we guarantee we have the right diagnosis? Psychological testing.
Well, psychological testing is helpful, but really bipolar is a longitudinal diagnosis. And I know many of you know Dr. Pandurangi. He's spoken to this group many, many times. He's much more. And when he's evaluating someone for diagnosis, he'll basically draw out, on a piece of paper and say, okay, let's start out here. And, when was this episode? And you really have to look over a person's lifetime, or at least, young adult lifetime to see. And you almost always need collateral history because, like we talked about, the person themselves often doesn't remember the mania or doesn't remember how bad the depression was. It's like childbirth. Who wants to remember it, right? Nobody would have more than one kid. So really having a family member or collateral history or old records, is going to help you. My colleague, who's a child psychiatrist, even with adults, she sometimes tries to get school records because you can learn a lot by, looking that far back.
Okay, we're almost at the end here. I'm happy that you mentioned CBD. My son is now taking CBD to fall asleep, and I was worried about it compromising his lamotrigine.
Yeah, I would have to look it up to see if it's like any kind of, a drug interaction like with the enzymes, but it's not going to make him psychotic, thank goodness.
What is the difference between bipolar type 1 and type 2?
So in bipolar 1, a person has full-blown manic episodes, the stuff that's really dangerous, and they can have psychosis. In bipolar 2, you're not bipolar 2 if you've had a manic episode, you're bipolar 1. So bipolar 2 is episodic depression and low grade or hypomania, and bipolar 1 is episodic depression and mania. But the treatments are really the same. Except for what we talked about with the antidepressants, that you definitely don't want to use those in bipolar 1.
And I think that was all the questions directed to you. One question might be more for Linda. Will there be certificates of attendance for CEUs, continuing ed?
Yeah, I will have to check on that. I'm not sure.
Okay.
Maybe that person can send me an email and I can respond back to her.
Okay. And someone asked if this will be if the video will be available, and I believe it will be on YouTube on the NAMI CVA site when we get it posted, probably a couple days.
Right.
And then there was just a lot of kudos for you presenting this information, how informative it was, and also some well wishes on your upcoming run.
Oh, thank you. Well, and here's my support system right here. This is my
doggy
and my support system, who wasn't allowed up here because he during the presentation.
There you go. Hold on.
I will. Here we go.
Great.
And I think I got everyone's questions. If I missed one, I apologize. It's hard to go through the chat and get them queued. I hope I didn't miss any. If I did, I apologize. Just throw it back in the chat. But I think we got everything.
Yes. Thank you so much for putting this presentation together and your time to speak with us. We really appreciate it. It was very informative. And I want to thank everyone for joining in tonight.
Thank you. It's really been an honor, and I'm looking forward to my run to raise some money to help you guys on March 20th. And you all
Yes, and
day.
I believe we have something on the website about that as well. So
Can you just real quickly tell us what the run?
Sure, I'm going to put Floyd down. Thank you. Okay, I don't want to drop him. It's a long way down. So, you know, I'm a long distance runner, and with COVID, all the races I did, you normally would do marathons and half marathons were canceled. And normally I would have, you know, been out there running with other people, which is what I really love. But instead, I've mostly been running alone and a little bit with friends. And I've spent a lot of time on the Capitol Trail. And I got this idea a few months ago that I wanted to run from Richmond to Williamsburg on the Capitol Trail and donate the money that I would have used for race fees to a worthwhile, you know, organization that's helping people get through COVID, and as a tribute to what COVID, you know, everybody touched by COVID, the families, the individuals, the healthcare professionals, and people who, you know, are living with mental health issues, dealing with the isolation. And so I couldn't think of a better organization than this. So I'm going to get out there and, you know, hopefully, God willing, and the creek don't rise, run from Richmond to Williamsburg on March 20th. And I'm going to donate, and I'm asking my friends and stuff to, if they feel like it, to donate. And if anybody else is a runner and wants to run a mile or two with me, come on out that day and join me. So.
yeah, that's wonderful.
51.7 miles.
Yeah.
My longest preparation run's been 33. So supposedly you can do 60% of the distance and still do it that day.
Wow.
Take a leap of faith.
Yeah. Well, it's very impressive to do that, and inspirational as well.
Thank you.
So again, I want to thank everyone, and I hope everyone has a good evening.
Thank you, guys.